So if you don't mind, would you please put in the chat your preferred name that you'd like to be addressed by, and where you are in your medical training, your career path. That'd be really helpful for me because I'm going to try to tailor this to your where you're at. Okay, Woody, you're over at SF, all right? Yeah, cool. Welcome, Woody. Okay, well, looks like Alexis is typing, and Nisha, and maybe Zoe will, and Paulina's note taker probably won't type. Hey, Zoe, great, welcome. Hey, Alexis, great, welcome. Okay, so we're talking about resilience today, all right? So we're gonna have a handful of learning points and learning objectives. We're gonna start out with just really basic define, right? So we're gonna define resilience. What is it? Recognize how it's impacted by medical education. There's a bidirectional component to it as well, right? So how medical education maybe fosters and hinders, right? And how your medical education might be affected by your resilience or lack thereof. Appraise the role. Is it Nini? If I pronounce your name wrong, I apologize. Please offer me some grace. Okay, so Nini, Alexis, Zoe, and Woody. Okay, I'm gonna call out on y'all, just so you know. Okay, appraise the role of your training institution in developing resilience, right? So, which is to say, while you may not be able to effect change necessarily or feel like you have control over certain concepts related to resilience in your institution or your system, you should be able to at least appraise the extent to which the system affects resilience, and maybe what you would prefer in a system if you had your druthers, right? As you look in your medical career, right? So for Alexis and Zoe and Nini, like if you're looking to have further education, you're looking at the next institution, Woody, for you, like residency, right? Where you're going to go, you're going to want to be able to appraise that in the program. And then examine evidence-based interventions to help develop resilience. And we'll talk at an institutional level and also at a personal level, just kind of depend on time, how this rolls. Okay, so usually I'll start with a case vignette or a clinical vignette. There isn't really a clinical vignette for this, but I'm just gonna, disclose a little bit of personal stuff. So this is my pops, right? This is my dad, Lauren. So this was 2014, New Jersey. He popped out to visit with me and to meet his grandson. And this was in June. And we had a blast, right? He was out spending time with me. The following month, he's a retired teacher. So the following month, July, it's vacation time, it's summer break. So he's in Hawaii and he's golfing. He's a golf instructor, throughout the majority of his life. And he's on the course, and I get a call from him. Hey, Pops, what's going on? And he says, hey, Drew, if I'm short of breath and I've got a pain in my chest, do you think I need to go to the hospital? And I was like, yes. And he's like, but I'm almost done with my round. I'm doing pretty well. Like, do you really think that I need to go? Like, can I just finish my round first? And at this point, I was like, the son, right, was incredulous and laughing. The physician was aghast. And so I said, yes, go to the ER, right? So my dad went to the ER, and sure enough, he'd thrown a PE, pulmonary embolus. So he was diagnosed and treated there. And then he had some other lab work that was kind of sketch. So they shipped him back to the mainland to get some additional lab work done and testing. So that was July. By September, he'd gotten his diagnosis of pancreatic cancer, and he underwent resection, and he started 6 months of chemotherapy. During those 6 months, he continued to visit with his 6 children, his 23 grandchildren at the time, try to stay as active as he possibly could, kind of traversing the United States where all of us live. The following year, this is July of 2015, he's back at the scene of the crime. He's spending time with his grandson. I was able to go out there and spend some time with him. He's still pretty laid out, like post chemo, but he was re-engaging in life and traveling the island with us, hiking a little bit, not a ton, but hiking, getting out, and really being involved with the family, which was beautiful. And then 2 months later, he went to the big house, right? University of Michigan, if anybody's a football fan. and he saw our BYU Cougars get slaughtered 31-0, but that's okay, right? Because the joy's in the journey. And we were high up in the stands. We couldn't afford good seats, but he gave it, he was giving it to the Michigan fans there. We had a blast. And it was just a really, really beautiful time. So October, about a month and a half later, my wife is pregnant with our second child, and she is in her first trimester, and she's diagnosed with Hodgkin's lymphoma. And so she started, she was scheduled to start chemotherapy. She had to get out of her first trimester before she could start. And my father was extremely supportive. He was on the phone with us regularly. He was a key supporter of us, helping us through the process, which was understandably quite scary and unknown, right? And he and my mother, committed to come out a couple of weeks later to be there for us, to provide childcare for our son, so that I could be with my wife during her chemo treatment, right? Her first treatment was scheduled for November 9th. So they're going to be out that week beforehand and the week afterwards. And those plans remained in place until around November 6th-ish, 5th-ish, when my father was placed on hospice care. And he ultimately ended up passing away November 8th. So that Sunday. And then my wife went into received her first treatment the next day. So why do I share this? I share this because we all have incredible examples that are very powerful of what resilience is. And they're likely folks like my father or like my wife, although she's an incredible example of resilience. She's not the subject of today, and I've already shared too much, so we're not going to talk about her. But invariably, each of you has somebody who has demonstrated, who has role modeled resilience for you. And I would love in the chat if you would just share with me like who that person is. Somebody who's demonstrated a role model resilience for you in your lifetime. I'd really appreciate that. I think sometimes we also may not recognize the fact that we ourselves are that example of resilience for somebody around us. We're actively modeling it for somebody, and we may not know until after the fact. Yeah, what do you think for sharing? Parents and other relatives, your parents, Alexis? Thanks. When we talk about resilience, there's no formal definition of that. Oh, both of your grandmothers, Zoe. Wonderful. There's no formal definition of what resilience is, depending on who you talk to. So I'm a psychiatrist. The American Psychological Association states that it's successfully adapting to difficult or challenging life situations through mental, emotional, and behavioral flexibility, right? But in general, we're talking about these core concepts of there's some form of adversity, difficulty, setback. You have elasticity, or you have the ability to bounce back in the face of this adversity. That's kind of the core of what resilience gets to, right? And so I think an important concept here is that resilience isn't necessarily a trait, like you have it or you don't, right? I like to encourage us to look at resilience as a process. You may have some resilience, but your resilience could be on a journey of its own, and it can grow, it can improve, you can develop it if you feel like you don't have it. Okay, so it absolutely is malleable. This is a really difficult time. Woody, you could probably attest to this, and Nisha, Alexis, and Zoe, you'll probably come to learn this, that med school is a very difficult time. Like your training is hard, right? You are in undergrad creating connections and then losing them. In med school, you're creating connections, then losing them. In residency, you're creating connections and losing them. Fellowship, creating connections and losing them. Amidst all of that, you may be traversing the United States, or internationally, depending on where your training takes you. And there's just a lot of loss. It's tough. It's really, really tough. And then you add to that the fact that this age group is by and large when the vast majority of folks who will have mental illness manifest it, right, for the first time. And that's not just you, right, but that's your loved ones, that's your support network, okay? And add to that this is likely the first time that you've come across the fact that you have to own a clinical decision and the outcome. You have to deal with very unhappy folks and meeting their needs, developing therapeutic rapport. You can't just walk away from, like, unfollowing somebody on X or something. Like, you have to sustain these longitudinal relationships with patients, with other peers, with your attendings. And this is hard. That you likely have been trained for this, but you may not have had to actually implement it before. Most medical students say that the most significant or stressful events that they have to deal with, right, are these ones here, like applying clinical knowledge, adjusting to clinical settings, the verticality of different environments, what the hidden curricula is, things that you're supposed to know but you don't know, right? Understanding your role, and then being exposed to trauma. It may be that you have never experienced trauma. It may be that you've never been exposed to what that's like. In my 10 years of being in med school, residency, and fellowship, I had 7 moves and relocations, 3 different program directors, the deaths of my 2 grandparents, the death of my father, 3 failed relationships, one, successful relationship, I guess. I'll say that unilaterally without my wife hearing. The birth of my first child. I had my first delirious episode. I had my first panic attack. I had my first failed code blue. I had my first assault by a patient. I had my first suicide homicide of a patient and his wife. And I'm just a regular dude. And I went into psychiatry, right? So these are action-packed years for you. And many of these things are not necessarily within your control. And so you have to be able to prepare for that, perhaps in some way. You look at what medical school tells us about resiliency, and the lit is overwhelming, okay? That there is a direct buffering effect of those who have resiliency and or are resilient on the physical demands and quality of life of your time during clerkship, right? So your clinical rotations in medical school. There's direct correlations with life satisfaction, happiness, subjective well-being, as well as anxiety and depressive symptoms as it relates to resilience. I don't think that's surprising to anybody, right? I'm reminded of this Brian Regan bit where he talks about going to his doctor and telling him he has heartburn, and his doctor gives him a list of things that cause heartburn. He's like, "Doc, I already know how to get it. I want to know how to treat it, right? We already know that resilience helps. It's like, how do I develop that resilience, right? This isn't likely groundbreaking for many of us, but I need to put it up here because we have to acknowledge it. It has to be stated that resilience is extremely important in your medical career and all facets of it. And one thing that more and more in the literature for the past maybe 12 or 15 years we've been open about is burnout. And so, these numbers are pretty staggering compared to college grads. 50% of med students are burned out compared to 35% of college grads. 50% of residence fellows have burnout, right? 30 versus 31% of college grads. So the numbers are pretty stark. And it's, for many folks, not almost like a matter of if, it's a matter of when. And so while there's a very strong correlation between resilience and burnout, I'm going to try to avoid that for the most part and try to talk about resiliency, because burnout would be a completely other presentation. But I want us to keep that in the back of our minds as well, right? The burnout is a significant factor, and it has very severe consequences, right? When we talk about the increased rate of suicidality, 3.5 times the rate of suicidality, or twice the rate of attempted suicide. So these aren't just hypotheticals, right? These are really tangible, life-altering things. The nice thing, right, is that if resilience is more of like a process than a trait that you either have or don't have, then it can be taught, right? So there's hope for all of us. So how do we get at that, right? How do we get at what resilience is or is not, and how we can implement in our lives a little bit more, okay? And so as we talk about that, we have to step back and acknowledge that we are complex individuals, for better or for worse. And that complexity exists in a hierarchy of systems. There is no one system that takes predominance, and there are proximal and distal components of each of these systems. Nevertheless, you have to be mindful of each of these systems as they interrelate with your resilience. There can be some systems that hinder and some that help your resilience. And in this presentation, we're going to focus on more proximal things as opposed to larger, systemic ones or environmental ones for the most part, like in community or politics or what have you. But I want to acknowledge that there's many layers to this, number one. Number two, I also want to acknowledge, and we'll bring this up a little bit later, that resilience that focuses only on one system are less likely to be successful and less likely to have long-term benefit. So as we talk about this, stuff, I want you to keep in the back of your mind, oh, wait, Dr. Magrin said I have to do more than just this, right? There has to be another change. There has to be another implementation. There has to be another level of how we approach this, okay? But for our, 30 more minutes together, there's only so much I can address, right? So we look at this, and I want to seed this, right, for Woody as you look at residency, and then Alexis and Zoe and Nisha as you look at what component of healthcare you want to go into, what institution you want to go to, or what school. I want to empower you, right, as opposed to just simply looking at location and looking at maybe pay or benefits. I want you to critically evaluate what the culture is like in that system and the extent to which it does or does not support your resilience, because that absolutely should be a key factor of yours. And if it's not, I strongly encourage you to put that near the top of your list. There are certainly institutions that promote well-being and some that don't. We talk about this idea of a double standard, and I want to acknowledge it, which is to say the culture of medicine is that we expect our physicians to just sacrifice everything, right, for the greater good. And it's an incredible thing, and it's a beautiful thing, and I don't take that lightly, and I willingly take that on. And I also acknowledge that it's not fair to say that I need to do that and not let myself get burned out, right? Like, what is that? So I can't do both, or I can do both with a supportive system and with realistic expectations. That has to be said, has to be acknowledged, right? We have to be very straightforward about that. And so we talked about a hidden curriculum. I'm teaching you stuff right now. You have my slides, you see my points. That's my curriculum. What's the hidden curriculum? What's not being said? When your institution spends money to buy an athletic facility as opposed to a new mental health facility or an OB-GYN facility, or they hire more X as opposed to more Y, that's the hidden curricula. That's what they're telling you is important to them. So that's why they're spending their resources there. So what is the hidden curriculum of your institution, of your system where you're going? You need to critically appraise that before you enter into it and see, is this something where a place where I want to be that keeps me healthy? There's one paper that talked about this, which I thought was hilarious, right? So this idea of essentially gaslighting, right? That wellness programs implement in environments that don't support self-care may unintentionally cause distress. Like, for me, that was very reminiscent of my last job. I worked at a place that had unlimited time off, unlimited vacation. The caveat is that I had to get coverage. So I couldn't find coverage. I could not find a peer who would take over my, I worked as an inpatient geriatric psychiatrist, who would take over my inpatient panel. More than it ended up being about 2 weeks a year. So although I had unlimited time off, I could only actually use 2 weeks a year. Okay. Woody's laughing about that. And I'll tell you that that was distressing to me. That was undermining to me. And you should laugh, Woody. It's silly. It's totally silly. It's totally fine. I'm not calling you out. Like, I appreciate that you're feeling the pain with me. Yeah. But I want to make sure that we acknowledge that there's a difference between adversity that allows us to pivot, change, grow, adapt, and find success, and then adversity that is simply adversity, right? My system did not allow me to overcome that adversity. They did not put me in a position where I could bounce back, where I could demonstrate flexibility. So I had to get out of that system. That was very unhealthy for me. And so I did, and I'm in a much better place now, which is wonderful. Not so subtle plug for Kaiser Permanente. And then there's also this concept, which I alluded to a little bit before, which is that if we have physician directed or person directed to Zoe to Alexis change, that's great. But what improves and here it's burnout, but I'm just going to bring resilience in as a corollary because they're so closely tied together. That organizational change is what really has the most drastic impact. You can imagine that a physician directed intervention to have unlimited time off sounds great, but if the system doesn't support me, then to what end, right? Okay. So as we're still talking about this institutional concept, like how the institution can support your resilience, I bring up this idea of work-life balance. Is somebody willing to come on mic and tell me what that means to them? I can't hear anybody if somebody's talking. No? All right. Looks like Woody's trying, but I can't hear Woody, so I'll give you A for effort, Woody. Okay. Alexis, Nisha, Zoe? Tough crowd. Okay. Well, um, there you go. Okay. Work and life have to be balanced. There's an implicit assumption that the two are mutually exclusive. Great. Could you repeat that? I don't know why I can't see the slideshow. You can't see the slideshow, Alexis? It's ridiculous. Okay. I don't know how to address that with you in the moment, Alexis. I'm sorry, I can't be IT support for you. But you can hear me. So what does work-life balance mean to you?
Can you hear me?
Yeah, I got you.
Okay. Work-life balance is kind of, to me, kind of like, for lack of a better word, I'd say there's not being a workaholic, kind of
Okay.
like being able
Yeah.
to take time for yourself.
Yeah. Great. Okay. Time for yourself. Putting not being a workaholic. That to me has a lot of negative connotation, right? Workaholic, alcoholic, right? We don't say a lifeaholic, right? But you're talking about workaholic. So just like Woody kind of talked about, there's this idea that the two are mutually exclusive or that one is good and one is bad. Work is bad, life is good. We must have a balance between this good and bad force, or these good and bad forces, to find some sort of stability. I'm going to push back on that narrative, and I want to encourage you to push back on that as well. Okay. So some folks will say work-life balance is not working a lot, okay, for lack of a better term. Some will suggest that it's a dynamic equilibrium, which I agree with that very much so, right? It's constantly changing, and it's not a balance, but there's certainly an equilibrium. Life sometimes is quite bad. When my father passed, when my wife was going through chemo, those were pretty bad times. Like that wasn't good. I wanted less of that and more of the work, frankly. But there's times where work is bad, right? When my patient killed himself and killed his wife in the ICU, that was bad. I wanted less of that. I wanted more of my family. And so what I'm getting at is we need to step away from clearly one is better than the other. We need to look at the idea that both can be healthy and should be healthy. And so how do you find that healthfulness in your life? We talked a little bit about finding the right institution, right, that supports that. I'd encourage you to think about finding an institution where work or being and feeling healthy does not mean getting away from work. That being at work, being with your institution can mean that you feel fulfilled still. And it may not be that you're doing clinical work there. It could be that they have something that aligns with your mission. So like Kaiser Permanente has the KP Cares organization. I can go and do service in the community. I feel fulfilled. I feel valued. That's something I like to do anyways. It helps develop my self-efficacy. I serve the community. I develop empathy in a non-clinical way. That's with my institution. It helps me feel resilient within my institution, but it's not clinical work. It's a nice work-life balance. I'd be doing it anyways in my personal life. So think about how can you find that balance, but doesn't necessarily mean being away, right? I think that's a key part of resilience. There's also this idea of dynamic flexibility. We talk about resilience being this capability of adapting, changing, pivoting, being elastic, bouncing back, right? So dynamic flexibility, does your institution do that? Do they role model that idea of pivoting and flexing and adapting? So if, Zoe, you come and say, hey, we're looking for this type of clinical experience, and your institution says, well, we don't do that. Like historically, we don't do that. It'd be too hard for us to do that. We're not going to implement that. Or if Nisha says, a lot of people are working from home nowadays, it's really important that I learn how to work from home if I want to be competitive in the labor market after I graduate from your program. say, well, we'd have to build that out. It'd be too hard for us to implement the workflows and the structures, so we're not going to do that. That doesn't demonstrate resilience. That doesn't demonstrate flexibility. And so what's being role model? What's the hidden curricula there, right? And so you want to find a place that allows you to do that. We have a couple of residents who felt very, very strongly about serving outside of Kaiser Permanente. That doesn't align with Kaiser Permanente's model, right? Serving outside of Kaiser Permanente if you are a Kaiser Permanente resident. Nevertheless, it does align with the model of our community needs care and we serve our community. And so absolutely, we were able to set up rotations with Alameda Health Alliance at John George and at, this may not mean anything to y'all, to 2 local county sites, and then to Contra Costa Behavioral Health Services. Our residents felt very strongly about being prepared to work from home, that they need to be able to manage their priorities. They need to be able to time shift responsibilities. They need to know how to work in different environments, the professionalism and developing rapport through a camera as opposed to in person. So we implemented work from home for them. Right? We're one of the few programs around here that does that. So these are key components where we demonstrate dynamic flexibility. And hopefully that is the hidden curricula that our residents come away with, right? That they learn that they can still find success amidst adversity or change by pivoting. Most institutions will have some component of a mentorship or peer support network. I would highly encourage you to investigate that, to see the extent to which it could be successful for you in developing your own resilience. There's a couple of core concepts here that may be or may not be familiar with some of y'all. So I'm happy to go through them. If you have questions, by the way, feel free to just put them in the chat. I'm happy to answer them in text. But one thing that really resonates with me when I think about mentorship, like my mentors, is this idea of being able to have a safe place. Psychological safety is, I'm going to say it's a buzzword. It's very genuine and sincere, but nevertheless, it has taken on a buzzy type of flair, unfortunately. But the core of it is that we are all human. We're all prone to bias. We're all prone to mistake. And so I hope that Zoe gives me grace. I hope that Alexis gives me grace when I make mistakes, right? And I try to do my best when I try to be resilient, right? And to adapt and to overcome and to spring back, right? And so when I look at a mentor, I want a mentor who's going to not only role model that for me, but actively encourage that in me. So there's this concept of emotion-free mistake making, which is essentially mistakes aren't good or bad. I shouldn't role model necessarily anger, distrust, guilt, shame, fear, these types of very negative emotions with mistakes when they occur. But I should address the fact that a mistake was made and how it can improve. I should also, as a role model, demonstrate my mistakes and call myself out. I should be comfortable with the idea that my residents know that I'm human. They should be comfortable knowing that Dr. Magrin's going to make mistakes. He makes a lot of mistakes, and he's willing to own up to it, and he's willing to make it right. And that's what's important. And that hopefully is empowering for folks as they try to get over this idea of an imposter syndrome, or get over the shame response that naturally comes with making mistakes, feeling like you have to take ownership of these decisions. You have to be the perfect person, the right person, the XYZ person in the moment, which is not a realistic expectation, frankly, for most of you, depending on the situation you're in. Self-forgiveness is something that unfortunately our society has kind of forgotten, and we don't allow each other to be forgiven. We don't forgive much. We hold people accountable for tweets and messages that were made 5, 10, 20 years ago. We don't allow each other to be human. So I encourage you to find a place where your mentor allows you to be human and helps you to be better, right? That's how you become resilient. There's also this concept of envy. Many of you might be familiar with it. There's actually good envy and bad envy. You put that in your wow box and you can bust it out at a dinner party. But malicious envy and benign envy, right? If anybody listens to Simon Sinek, who I align a lot with his thoughts. If you haven't read The Infinite Game, I encourage you to do so. But he talks about something called like a worthy rival, which is somebody who you aspire to be like, somebody who challenges you, somebody who pushes you, somebody who makes you want to be better. That is benign envy. That is acknowledging that there is a discrepancy between what a benefit, a capability, a characteristic that another person has, that discrepancy exists, but using it in a positive way, right? As opposed to malicious envy, which is using that discrepancy in a negative way to tear down, to pull down, to destroy. Okay? And so having a mentor who can model, right, emotion-free mistake making, this idea of being human, minimizing the shame response, helps encourage in you and develop in you this idea of, oh, I can make mistakes and be better. I can find somebody who also makes mistakes and wants to be better. I can try to be more like them and be better over time. I don't have to pull them down to make myself feel better. They don't have to pull me down to make themselves feel better. Okay. You may be the type who thrives in a competitive setting. That's perfectly fine. You know you. I would just encourage you to find a competitive setting that's more benign than malicious. Okay. A competitive setting that makes you and everybody else better. We have so much need in our country for high quality healthcare. There is minimal place for malicious envy. We need to build each other up. We need to have better communities where we make each other stronger and more resilient. That's going to make us better as healthcare providers. It's going to make our patients better, make our system better. So I just strongly encourage you to do that. Okay, what else on the slide? That's it on that slide. Okay, so let's talk about this. Okay, so we're talking about the system, we're talking about institution, right? Concepts about resilience we should be mindful of. Now let's drill it down a little bit to us personally, right? So Alexis, what can you do, right? Alexis said that her parents were examples of resilience. I imagine, Alexis, your parents may have manifested some of these. If you notice any of them, like shout it out. Anybody else, if you notice things as we're talking that you have seen in your system or things that really resonate with you, put it in the chat so I can engage with you on it. That's okay if not, but I want to make sure you feel like you're involved. Misha, sorry to see you leave. Miss you. Okay, so build personal resilience. There are some very core concepts that I think fall into this idea of wellness that I introduce here. I'm a psychiatrist, I can't not do it. Some of them might be more valuable than others, but I just want to, I should have brought forward that image, I apologize. But I just want to bring up this idea of stress management, emotional regulation. We talked about these years are going to be extremely difficult for you. And so you're going to have to find a way to cope, to manage stress, to regulate your emotions, to regulate your behaviors. Okay? And for all of us, there's different ways of doing that. I say a highly evidence-based one that's extremely easy to implement. This is the idea of progressive muscle relaxation. This is from the VA. You can find any number of, not workflows, but what's the word I'm looking for? Flowcharts or processes through which you can do progressive muscle relaxation. This got me through medical school when it's 3 a.m. and I have insomnia about my exam the next day, and I just progressively relax my body and I'm able to fall asleep for a handful of hours. So this is an easy one that you can do at any given time. There's also this concept of growth mindset, self-efficacy, and effort. These are kind of buzzy words too, but I want to cut through them a little bit and introduce them because these absolutely are things that you have power over as well and that you can effect change in. So self-efficacy, this is one's ability to manage challenging tasks and or situations. This is your ability to effect change, right? If X situation presents, I can implement something that will change that situation, right? And this is something that could be developed through effort. You may have similar to resilience, you may have low feeling of self-efficacy. That can change over time to where you have increased self-efficacy. But again, that takes effort. Resilience takes effort. Okay. What is a growth mindset? That's a buzzy word you're going to see like in Harvard Business Review if you look over the past 10-ish years, maybe 15 years as well. I think the crux of growth mindset, though, is that there's folks who feel like they have talents that can be developed. They can put forth hard work. They can take input from others. They can implement good strategies and modify things and get better. That's a growth mindset. There are folks who feel like they have innate fixed talents. These are people who have fixed mindset. We try to I would steer us away from individuals, or steer us away from the idea of a fixed mindset that is counterproductive to developing resilience. I also want to submit this idea that self-efficacy improves with effort, growth mindset improves with effort, or putting energy into your own learning. This idea of effort keeps coming up, right? So I put some questions there. There are certain people who are just no good, and there is some good in everybody, right? One of those probably aligns more with you. Just keep in your mind which one it is. In my case, getting what I want has little or nothing to do with luck. Many times we might just as well decide what to do by flipping a coin. Again, one of those probably aligns with you. Who gets to be the boss often depends on who was lucky enough to be in the right place first. Getting people to do the right thing depends upon ability. Luck has little or nothing to do with it. So one of those two probably resonates with you. If you picked 15B and if you picked 16A, then you get a point. Congratulations. These are 3 questions from Rotter's locus of control scale. And the more points you have, the more external locus of control you have, which is to say you feel like decisions are outside of your realm of control, influence, possibility. You are acted upon. You do not act on things. And so you want to be mindful of that. We're going to talk about this in a moment a little bit more. The effort counts twice. There it is. Okay. So this is from Angela Duckworth. She had a really great book a handful of years ago called Grit, The Power of Passion and Perseverance. You can see it down there. And one thing she talks about are these 2 formulas. She says talent, which each of us is given or we are born with, it's an innate ability. Talent becomes skill through effort, right? I may naturally be able to play the piano, but if I don't put forth the effort, I won't develop a skill to do it with regularity or frequency. That skill only becomes something noteworthy of achievement or accomplishment as I put forth more effort to develop it. And so her big thing is effort counts twice. Okay. So here we've seen the effort counts twice for, this is grit, but for achievement. Self-efficacy, a core component of is effort. Growth mindset, a core component is putting forth energy or effort. I don't know if you get the hidden curricula I'm trying to convey to you, but you absolutely have control over effort. When you are building your personal resilience, your effort matters a lot, a lot, a lot. So please don't forget that. Okay. And here's another thing I'll just put here, which is that your goals are extremely important and you should be intentional about them. If it's worth doing, it's worth doing right, as my grandmother said. And one of the best ways to be intentional about your goals is to create a hierarchy of them. Folks who created a hierarchy of goals were more organized. They had greater resilience in the face of daily frustration and increased sense of control about completing their goals than those who didn't. So put forth that effort, be intentional. There's something called deliberate practice, right? Not just practicing, but deliberately practicing a nuance or a facet of a particular act or behavior, and be intentional about what you're practicing. And that's how you improve. Okay. So you need to be intentional about your goals. If you want to achieve them, be more likely to achieve them. And if you want to build your resilience. Okay. Last slide of personal resilience. What else we can do? Okay. Mindfulness. Again, psychiatrist, you can't get through a presentation without me talking about mindfulness. So mindfulness is how you can purposefully and in an uncritical way focus on your internal and external experiences, your stimuli, your emotions, your cognitions, your physical feelings, right? That is mindfulness, right? Being in the moment is how a layman might approach it or present it. And so mindfulness is closely interrelated with this idea of internal locus of control we just talked about right on the last slide. So the extent to which I believe I can control or effect change in my life, that my own actions and my personal characteristics can result in tangible changes, right? And there's this really great study that demonstrated what they call a chain mediating mechanism, which is to say that folks who had mindfulness or higher levels of mindfulness subsequently had higher levels of internal locus of control and had higher levels of resilience, which resulted in higher levels of benign envy, right? So All this to say, resilience is closely correlated with and directly proportional to your mindfulness, your level of mindfulness, and your level of internal locus of control. Okay. For those that are familiar with CBT, cognitive behavioral therapy, this is a modality of talk therapy that we do where people evaluate their thoughts and emotions, the emotions that come from those thoughts, and the behaviors that come from those thoughts and emotions, and then act, right, to reverse that trend if it's unsuccessful, or benefit that trend or empower that trend if it's successful. So CBT has been adapted to multiple specific conditions. CBTI for insomnia is a very classic one that you'll hear about later on, or you may be familiar with and use. But CBT for resilience has been studied and implemented as well. Here's the model they use for a personal model of resilience. What I'm getting at here is that, again, resilience can be taught. You can change. You can, in effect, change in your level of resilience with intentional action. Right? And this is the last one that I'll address with personal resilience. This is not gaslighting. I am not saying sleep with the knowledge that you can't sleep, or I give you so much work that you cannot sleep. This goes back to the idea of institutional resilience, and if you're in a healthy institution, that sets you up for success. While there's multiple things within healthy lifestyle that I could address, I just want to hit sleep just to underscore this even more so. You are potentially in or looking to go into a career that will invariably put you in a position of sleep deprivation, perhaps even chronically. And while you may not be able to control that necessarily, you can certainly try with where you go and the discipline that you pursue. Invariably, you're still going to have times of poor sleep. The literature is very clear. 17 to 19 hours of poor sleep, you're operating at about a 0.05 BAL, blood alcohol level. Your response speed is 50% slower than it would be otherwise. In fact, actually, some of the performance measures are worse than if you were intoxicated at BAL just after 17, 19 hours without sleep. And so you're saying, okay, so you're telling me that I'm not going to sleep well. You're showing me a Gallup poll that says that 57% of Americans say that they need more sleep. So we're already working at a deficit. You're putting yourself into a position where you're going to have even more of a deficit, right? So how can I say you need to sleep more when you're already setting yourself up in two different ways to have poorer sleep? And what I'm going to say to you is you need to be as protective of your sleep as you are of anything else. Sleep is the catalyst for you to have success in the day. You cannot have success if you don't sleep well. And if I know that I'm not going to be drinking water for the next 48 hours, I'm probably going to drink some water. I know if I'm not going to be eating for the next 48 hours, I'm probably going to eat something. If I'm not going to be sleeping well because I'm going to be on long call or I'm on overnight call, I'm going to tank up and I'm going to get sleep. Alexis, you're not going to get better at sleep deprivation by being sleep deprived. Okay, this isn't like a skill set that you're going to build. You always do poorly with sleep deprivation, just always. But the way that you can mitigate that is by being intentional and protecting you, right? I think I have one more slide. Yeah. So here's another slide you can see since 1942. Just Americans are sleeping less and less and less. We're just not being very intelligent about what we're doing with our time, unfortunately. Or we feel like we can't sleep, that other things take precedent, which is unfortunate, right? I want you to prioritize you. You have to have the building blocks to be resilient. You can't put yourself at a deficit and expect to overcome your own adversity as well as the adversity that life is handing you or your job is handing you. Help yourself, right? Put yourself in a position to be successful. Okay, so this is my last slide. I'm at time, but this is my last slide. So why is resilience important after your training? There's a lot of lit about this. So I'm just going to have it up here so you can look at it. And it should not be a surprise to you. But folks who have low resilience have a higher incidence of burnout. Folks who have a higher incidence of burnout have reduced empathy. They are less interested in caring for underserved populations. They have more unprofessional behavior. They have less altruistic views about physicians' roles and responsibilities to society. If I look at the if I look at the personal statements of the residents who apply to our residency program, this is anathema to what they espouse they want, right? They want to serve communities that are underserved and marginalized. They want to be empathic. They want to be professional. They are very altruistic, sometimes even romantic about the idea of medicine, okay? So why would you put yourself in a position where that is threatened? This brings you joy. So put yourself in a position where you can have that joy and that fulfillment, right? So be mindful of your resilience now, and it's never too late, right? It's a process. So even, if I hadn't started it yet, I could start as of 2 weeks ago when I started making this presentation, right? And I could still be successful. With regards to the career, they've done studies in just emergency medicine physicians, but then also in all physicians and consistently, right? Resilience related traits or resilience are directly proportional to sustained engagement, retention, sense of meaning at work, and longevity and productivity. So this has far-reaching effects, and I didn't go into the personal domain. This is mostly a professional, like that I was focusing on, but absolutely has adjacent benefits to personal domains as well. But your resilience is going to be a key contributor or a key detriment to your success. And I hope that our time together may have emphasized that, but also provided some hope and encouragement that it is malleable, it is changeable, and that you can improve and do better, that you have the ability to effect change when it comes to that. The extent that you can choose where you go and what you do, you have the power to effect change on your institution and your system, and that both of those should be keys for you, right? Don't forget about one or the other. You have to include both of those as you're making your decisions about your next steps. So it looks like I've lost everybody except for Zoe, Woody, and Alexis, but thanks for sticking around. So that's where I'm pausing. Any questions, comments, concerns?
Do you have any examples of how resilience has helped you in your specific field?
Sure. So in my field of psychiatry or my personal life, so I'd say my field of psychiatry, in my training program, just really quick, like I had a very turbulent training program, and like I said, I went through 3 different program directors, and that was a significant challenge. When you're trying to find your professional footing and maybe your personal footing, and you're looking for, appropriately or not, like somebody who might be a mentor or like a North Star, like to have that individual removed multiple times was a real threat to my development. So I think the ability to flex and adapt and find a key mentor who I could rely upon and peers who I could rely upon was an example of where I was starting to use resilience and recognize how powerful it could be. And then that just continued after that. And so resilience, or developing resilience, has been a key trait that I'm constantly thinking about. I'll say that it wasn't anything unique about psychiatry per se, but within psychiatry, maybe I'm a little more mindful. I have the time and the space to consider these things, maybe more so than somebody who's rounding on many people on the medical floor in the ICU or the ER, something like that. So emotion-free mistake making, yeah, different emotional detachment. So I would say emotional detachment. Okay, so emotional detachment is almost like that's a very negative thing in my mind. Like, you are removing emotion from the equation, the situation, which we shouldn't do. Which is to say, a tragedy happens, a mistake is made. There should be natural emotion. You're a human being, right? Unless you're on a mood blunting medicine or something, or you have alexithymia. So barring that, like, emotion should be there. You should have affect. Those are healthy, natural things. I think, and thanks for bringing this up, Woody, I didn't explain it well. I think more from a mentor side, they should role model a mistake, and they should not naturally attach an emotion to it before the mistake can be like processed together, like what the mistake was. And then you can talk about, like, what's the emotion you had? Here's the emotion that I had, right? And demonstrate that transparency. But I don't want to cede necessarily that I felt incredibly ashamed when I made this mistake that I'm modeling to you, Woody, right? So if we're recording, so I can't share too many examples, but like if a mistake was made, I can't immediately like share with you, like, I can't believe I did that. Like, that's so embarrassing as program director. How could I do that? That threatens my autonomy. That threatens the role model, like, role that I carry. Like, are people going to trust me still? Like, things like that. Like, I cannot demonstrate that immediately to you. I have to role model just the mistake and say, like, I can't believe I made that mistake. Wow. Like, I'm still making mistakes at this age, or 15 years after graduating. And then after that moment passes, when I do feedback with you at the end of our half day or day or whatever module, they say, hey, let's review like what happened. Talk to me about what it was like when you saw me make that mistake, right? So just giving a blank slate in the moment to allow you to make your own determination of what it was like and to have your own feelings and process it. And then later on, we'll talk about it. I think that's most of what it is. Emotion's still there, like value the emotion, super important, whether it's transference or countertransference or, shame or guilt or joy or whatever it is. Yeah. And don't stigmatize the emotion is what I'm getting at. Yeah. Now, Woody's typing. Anybody else? Anything? Yeah. Cool. Okay. I appreciate y'all. Thanks for sticking around.
Thank you. Thank you,
Yeah.
everyone, for attending. Thank you, Dr. Magrand, for presenting today. This is recorded too, so it'll be available for other students who registered or weren't able to attend. It'll be available on ConnectatKPNC.
Sounds great. Thank y'all.
All right. Thank you, everyone. Have a great evening.